I'm going to give it just a second while we make sure that the live streaming is set up. Okay, so I'm Dr. Kim Thornton. I'm a reproductive endocrinologist at Boston IVF. I've been practicing reproductive endocrinology in Boston since 1998, and then I was in Connecticut for 7 years prior to that. So I've been doing this for quite some time. Um, Thought we would just really start to talk about fertility and potentially your fertility journey. And rather than a lecture format, we typically like to do this in the form of a Q&A so that you can enter questions in the Q&A box, and then I'm happy to answer any questions that you might have. I have a few questions that were submitted already, so I'm going to start with those questions, and then again, I will answer questions as they come forward. So one of the questions that people ask me is, if you have anovulatory cycles, is that cause for concern? Well, anovulation is when women don't release an egg every month. And, unlike somebody who has regular cycles that are every 28 to 30 days, women with anovulatory cycles can go, as long as 60 or 90 or even longer. I usually term somebody as anovulation or oligoovulation, infrequent ovulation, as having cycles that are somewhere between 30 and maybe 60 days, and then completely anovulatory if you can rarely demonstrate that you have a period. In general, most women who are anovulatory, we're able to help them ovulate with the assistance of either oral medications or the injectable meds. So most anovulatory women, we start off with either letrozole or Clomid. And in this day and age, we typically use letrozole just because the side effect profile of letrozole is a little bit better. Letrozole works by decreasing the conversion of ovarian androgens that are produced to ovarian estrogen. And that in turn reduces the available estrogen to the pituitary. So the pituitary's response is to produce more FSH, which stimulates ovarian follicular development. So most women who are anovulatory, we can get them to ovulate with letrozole, or in some instances, we have to use injectable follicle stimulating hormone. But very often they'll be able to conceive successfully with just ovulation, induction, and intrauterine inseminations, or timed intercourse, depending on their preference. And those women who fail to respond, then we move on to IVF. Is there a specific cycle or day of the cycle at which the IUI procedure is done? Typically, IUI procedures are done in women who are either ovulatory naturally or ovulatory because we can get them to ovulate with letrozole or, in some instances, Clomid. We monitor the cycles, and cycles can be monitored either at home with the over-the-counter ovulation predictor kit test or with blood work and ultrasound, in which case we're looking not only at follicular development, but we're looking at estradiol rise over the course of the cycle, LH levels, and LH looking to see if a surge is starting or whether or not we're inducing ovulation with a trigger shot before the surge occurs. And so there's not a typical day in somebody who has a 28-day cycle. I would say most often the IUI is performed on cycle day 13 to 15 if their cycles are 28 to 29 days long. But it's either one day after an LH surge detected by the ovulation predictor kit or 36 hours after a trigger shot. The next question is, if you have a day 7 embryo, that is euploid, is there a good chance that it will implant and grow? So let me just step back and talk to you about blastocyst development. When we do or take a patient through an IVF cycle, after the stimulation and the retrieval, fertilization occurs on day 0. And from that point forward until the development of the blastocyst, that's about a 5-day period. So we first assess embryos to see if they've gotten to the blastocyst stage on day 5. But we will also, and that's the day that we would either transfer an embryo or biopsy an embryo for pre-implantation genetic testing and freeze it. We have found that embryos can also be biopsied on day 6 and day 7, and we've identified embryos that are euploid in both of those cohorts. And when that happens, the question is whether or not those embryos are okay to transfer back. We've actually looked at our success rates in terms of implantation rate and live birth rate based on embryos that are transferred back on day 5, day 6, or day 7. And, in general, embryos that are biopsied on day 5 and day 6 have implantation rates that are very similar. And then embryos that are transferred on day 7 have implantation rates that are slightly lower, but still a live birth rate that we think it's reasonable to do the biopsy and then transfer those embryos back. When we make the decision to transfer embryos, we typically select embryos that are biopsied on day 5 and 6 before we select the embryos that are biopsied on day 7. In general, the live birth rate for embryos, and this is data for embryos that have been tested, single embryo transfers tested with pre-implantation genetic testing, so we know they're embryos that are euploid. The live birth rate for embryos transferred that were biopsied, on day 5 or 6 is about 50%, with day 5 embryos implanting probably about 54%, day 6 embryos implanting or resulting in a live birth at about 47%. With day 7, the live birth rate is about 25% for embryos that we transfer that were biopsied on day 7, but still that's comparable to embryo transfers and untested embryos, but at least in this case, you're getting a euploid embryo back. For embryos that are untested, we've also looked at the outcome. And the live birth rates are slightly lower because, again, these are untested embryos, so we're transferring a lot more embryos that may be aneuploid. And so the live birth rate for embryos transferred between day 5 and 6 is somewhere around 35%. Again, day 5s are a little higher, day 6s are a little lower. And the live birth rate for embryos transferred on day 7 is about 14%. So from my perspective, it's still worth biopsying embryos on day 7 and transferring euploid embryos on day 7 if you have embryos that reach the blastocyst stage and are deemed good quality to freeze. Next question. What tests are recommended for women who have had repetitive failed embryo transfers of euploid embryos with no known fertility issues? I think this is one of the more challenging scenarios, just because we don't have a good answer oftentimes as to why embryos don't implant. Certainly if they're PGTA tested, we know that chromosomally they're normal. That doesn't necessarily mean that that embryo can't have any other abnormality, but the aneuploidy testing is certainly the best that we can do at this particular point in time. We spend a lot of time investigating or evaluating the uterine cavity. So in addition to making sure that the uterine cavity doesn't have any structural abnormalities, such as a polyp or a fibroid or adhesions, we can evaluate that either with a sonohystogram followed by a hysteroscopy if we find something, or you can be evaluated directly with a office hysteroscopy if your provider can provide that service for you. Oftentimes, endometrial biopsies will be obtained to look for endometritis, which is evidence of inflammation. We have done timed biopsies to look and perform what's called an endometrial receptivity assay to look to see whether the time we're transferring the embryos back meshes with what's thought to be a normal time to transfer the embryo based on kind of molecular analysis of the endometrium. We don't do that test routinely, but when there's nothing else, sometimes we will resort to doing that test. And then in addition to testing for endometritis, we might look for specific bacteria with a test that just actually will give us a bacteriologic profile of the endometrium. The data with regards to immune modulators, et cetera, is really not that strong. So typically, we can do that testing to see whether there's immunologic factors that may be involved. But I don't think that there's a lot of evidence to support a lot of the immunologic treatments that have been discussed online. I've done it occasionally, but it's not part of our routine. Next question. My husband and I have been trying for 9 months. 2 semen analyses have been performed, both in which were low in count and motility. And he's taking supplements to see if the count and motility will improve. She's looking for clarification if she should be hopeful for natural conception or accept that it may just have to be IVF. So when the sperm counts and sperm motility and even sperm morphology are low, I think the critical point is to, one, make sure that there's no underlying cause for the abnormalities. So it's really important that your husband see a urologist who has a particular interest in male infertility. Not only will he do hormonal testing, review the medical history, make sure there are no substances, medications, or whatever that could be adversely affecting the semen analysis. He'll make sure that there are no dilated blood vessels or varicoceles that could be impacting things. Make sure that there's no malignancy. Oftentimes men with low counts may have testicular cancer. It's not common, but certainly something that the urologist will look for. If there are hormonal issues that seem to be the cause of the low count in particular, urology may place your husband on a medication called Clomid, which will stimulate, the pituitary to produce follicle stimulating hormone, and LH, which stimulates the testes and may result in an improvement in sperm concentrations. And then certainly there are vitamins that have antioxidants in them that may actually improve sperm function. So if the counts improve with kind of this medical therapy, or if surgery is deemed necessary, if the counts improve, then I think it's reasonable to try intrauterine inseminations. But if the counts don't improve, then I would probably start with intrauterine inseminations and then move on to IVF. Next question. The question is, what does a segmented embryo mean, and is it safe for transfer? I think you mean for an embryo that has undergone pre-implantation genetic diagnosis. We get, depending on the lab you're working with, but at least the lab that we're working with, we get an answer back that the embryo is either euploid, which means that all of the chromosomes are normal. It's aneuploid, which means that all of the chromosomes are abnormal. And then in some instances, we get a result that says there's segmental aneuploidy. And that means that there is a portion of a chromosome, not the entire chromosome, that is typically duplicated. So instead of having, just as an example, if you have chromosome 8, and there are 3, instead of having just 2 components of chromosome 8, there's a segment of chromosome 8 there's actually 3 components. We would call that segmentally aneuploid. In some instances, those embryos will implant and self-correct, and the embryo will be normal. It really depends on how large the segmental aneuploidy is. So if it's a large defect, that tends to be more abnormal than a small duplication, for instance. And some chromosomes are more likely to implant with segmental aneuploidy and correct than others. So I think that we have elected, with additional counseling with additional consultation with our genetic counselors, to allow patients to transfer embryos with segmental aneuploidy if they're the only embryos that they have available, and if they have undergone genetic counseling, so that they know what the potential ramifications could be if this embryo in fact implanted and the segmental aneuploidy did not self-correct. But these embryos are typically the embryos of last resort. Another question: what's the best option with sperm DNA fragmentation of 46%? Can IVF work with this sperm DNA fragmentation, and what would be the likelihood of success? So when there is sperm DNA fragmentation, that means that there's a higher percentage of sperm where the DNA is packaged somewhat differently. And in most instances, the recommendation is for a couple to proceed with IVF and ICSI. The thought being that with ICSI, you're placing the sperm into the egg, the DNA unpackages and is okay. And so if that is the case, then hopefully fertilization and embryo development will be normal. There are some men that, I think that have very, very severe sperm DNA fragmentation, where even with ICSI, we still get poor embryo development. But we have to presume that if the embryo development is normal and if the embryos are euploid, that they should be fine to transfer. The likelihood of success, we've not really broken it down into what's the likelihood of an embryo implanting based on whether DNA fragmentation was present or not. So I can't tell you what the likelihood of success per se would be. I think if you look at success rates, most of the embryonic or most of the data with regards to success rates looks at age-related factors. So the older you are, the lower the implantation rates are. And, it's certainly concerning if you have diminished ovarian reserve, you have fewer embryos to work with. Next question is asking a question about ICSI versus ICSI when we're adding Zymot, I believe. And Zymot is a microfluidic way, and microfluidics means that you use small droplets and the sperm kind of swims through. But it's ideally a method to improve the selection of sperm that does not have DNA fragmentation. That being said, there are some men that have better sperm quality recovered after a Zymot sperm wash, and in some men it probably doesn't improve things. So oftentimes we will try the Zymot sperm wash if we've had poor fertilization with ICSI alone to see if we get a better quality of sperm. Sperm typically has lower percentage of DNA fragmentation if it goes through the Zymot sperm prep. But, everybody is different, so we don't always get better quality sperm or better fertilization rates. Question about egg freezing. And this patient is asking, my questions are regarding how many eggs I may have left and possibly freezing eggs. Is this the correct form? Certainly. So we offer fertility preservation mainly for two indications, really. Oncofertility, so those are patients who have cancer where they're anticipating going through chemotherapy, and the chemotherapy in most instances is cytotoxic so that it kills off all of the eggs. In that instance, it's kind of a no-brainer that an individual should freeze their eggs, because after that, they're likely to be menopausal or perimenopausal. For women who are just undergoing elective fertility preservation, the idea behind elective fertility preservation is that, you have X number of eggs at, let's say, if you're 30, right? And over time, the number of eggs that you have are going to decline and your fertility rates are going to decline. If you do not have a partner or do not have any intention of trying to conceive immediately or even in the near future, there may be some benefit to trying to freeze eggs at a younger age where the quality of the eggs is better, the yield of eggs is likely better, with the hopes that you will use those eggs at a later point in your life. Oftentimes for a second baby, because you may find that at 37, you either decide you're going to conceive on your own, or you have a partner and you decide you're going to conceive with that partner, and you have a baby, and then you come back at age 39, 40, and you're having difficulty, and then you have these frozen eggs that are effectively 30 years of age, right? And you can thaw those, fertilize them, and create embryos that will implant with the success rates comparable to a 30-year-old. Now, I can't tell you how many eggs you have left. What we can do is diagnostic testing with an ultrasound to look on day 3 for an antral follicle count. We can do blood work, in particular the anti-Müllerian hormone, which is a glycoprotein hormone that is produced by the small follicles in the ovary. And that gives us a sense not of the quality of the eggs that you have, but at least the quantity and whether or not you're likely to produce a lot of eggs if we were to stimulate you or not. The ideal age, in my opinion, is to freeze eggs somewhere between 30 and, let's say, 37. I think women who choose to freeze eggs in their 20s, most of the data seems to suggest that a lot of those women will never use those eggs. They're going to find a partner in their mid-30s, have their children, and the eggs are going to be in the freezer. Women in their 30s probably have a better indication as to whether they're, one, ready to either be a single parent or are in a relationship or are going to be in a relationship soon. So I think 30 to 37 is kind of the sweet spot. We will freeze eggs in women who are older, 38 to 40, even 41 or 42. But again, you have to remember that with aging, not only do the number of eggs that you produce that decreases, but the quality of eggs that you produce decreases. So you need to have more eggs frozen if you're older than younger women do. In terms of likelihood of success, based on our egg donor data, younger women are going to have a pretty good likelihood of success, probably with around 20 eggs, might have a 70% chance of having at least one live birth and may have enough embryos for a second. And then that number, the number of eggs that you need to achieve a live birth just increases in women as they get older. So I usually tell people they need somewhere between 20 and 30 eggs, depending on their age. And for women who are older, you may need more. The challenge there is you may not respond as well to stimulation. So, how many retrievals are you actually going to be able to do is, in many instances, driven by the cost of the procedure, unfortunately. This is a question from someone in terms of, is there a better time to try to have intercourse to optimize sperm function? And as far as I'm aware, there isn't. I don't think it matters. I think, or at least time of the day, I don't think matters. I think what's important is that you understand what your ovulatory cycles are like, So if somebody has a 28-day cycle, they typically ovulate around day 14. The most fertile time to have intercourse, and you can have intercourse every day, every other day, but the most fertile time is to have intercourse a couple of days before you anticipate ovulating so that there's sperm that's viable waiting in the reproductive tract for the egg as opposed to the other way around. The other thing that I would encourage you to do is have your partner not try to quote unquote save up sperm. In many instances, more frequent ejaculation is better because the sperm is fresher, more viable. So I hope that answers that question. So what supplements should we be taking besides a prenatal? This is a little bit of a tough question because there's lots of data with regards to supplementation. First of all, the prenatal that you're taking, you should make sure it has adequate amounts of folic acid or methylfolate and vitamin D. We oftentimes will recommend that women take coenzyme Q10. Coenzyme Q10 is a cofactor in the metabolic pathway of mitochondria, and mitochondria are the kind of engine driving embryo development. So that may help with embryo development. I don't usually recommend, DHA or DHEA rather. DHEA is an androgen. If you're taking it, it may increase your estrogen levels. Doesn't necessarily, based on my understanding of the literature, increase the number of eggs that you retrieve. There are women who will take growth hormone. Growth hormone is really designed for those individuals with growth hormone deficiency. The studies that have been published have suggested that with the addition of growth hormone, the egg yield after stimulation may be better. But there have not been studies that have demonstrated that live birth rates are better. I think the biggest challenge that we have is it's hard to change egg quality. And it's hard to change egg yield. So if your ovarian reserve is diminished, we cannot, as of yet, repopulate the ovary with stem cells that will result in more eggs being produced. So I hope that answers that question. Some of the other supplements that are out there, it's kind of hard to comment. I don't think that any of the studies have demonstrated, that they're effective in increasing egg yield, but things like inacetylcysteine, for instance, does not have any adverse effects. So I usually tell my patients it's okay to take them. Diagnosed with Mayer-Rokitansky-Kuster-Hauser syndrome. So that syndrome, for everybody else on Zoom, is where an individual is born without a uterus, vagina, and so the only possibility of trying to conceive would be using a gestational surrogate. The patient says, how can I find out if I have good ovarian reserve? The ovaries in patients with MRKH are typically normal and function regularly. So blood work to look at your antral follicle count and an ultrasound, blood work to look at your anti-Müllerian hormone and an ultrasound to look at your antral follicle count would be appropriate with the day 3 FSH and estradiol. Probably the best way to determine, when to do this testing would either be to just do serial testing like every week and you'll kind of figure out where you are in your cycle, or just test with the ovulation predictor kit when you have an LH surge, assuming that you're ovulatory, which I have to presume that you are. Then the luteal phase is normally 14 days. Day 3 would be 3 days after. So usually for my patients who don't have regular periods or don't have a uterus, I tell them to test for the LH surge and then do the testing 17 days later. I've had 2 blighted ovums, one in February, one this month. embryo tissue was tested after a D&C, and the embryo was found to be euploid. What would cause this, and what should we do for the next time? First of all, when you say the embryo was tested and was found to be euploid, I'm assuming that they were able to definitively tell you that that was fetal tissue. Sometimes you'll get information back that it's euploid female, and what actually is being tested is the maternal genetics. So clarify that, number one. The other thing is, other than genetics, there are a lot of other things that can cause an embryo not to develop. Structural abnormalities in the embryo, as an example, could prevent an embryo from developing further. So just because the embryo is euploid and transferred, the implantation rate is still about 50%, and then miscarriage rate, while not, your 15 to 20% of untested embryos, it's still around 10%. If this is the first euploid embryo that you've transferred, I wouldn't do anything different. As long as your uterine cavity is normal, endometrial thickness is at least 7 to 8 or greater millimeters or greater. I probably wouldn't do anything different. If you have recurrent pregnancy loss, so with the two blighted ovums, you may want to have testing with anticardiolapin, lupus anticoagulant, and beta-2 glycoprotein to test for, some thrombophilia causes. Again, make sure that the uterine cavity is normal. There's no polyps, no endometritis, and go from there. Is there any harm in testing for endometriosis with the Receptiva or a pelvic MRI just to have peace of mind? So the short answer probably is no. But, just to be more specific, the Receptiva tests for situations where there's inflammation. So it could represent endometriosis. It could represent an infection. It could represent inflammation somewhere else in your body. So I don't know if it's completely specific. The most definitive test for endometriosis is an actual tissue biopsy, which is obtained by laparoscopy. That being said, there's no harm in doing the Receptiva test. I think a pelvic MRI is a pretty expensive test. Oftentimes, we will have patients go to a GYN ultrasonographer who is very skilled at looking for deep infiltrating endometriosis, either in the rectovaginal septum or looking for adhesions between the ovary and the back of the uterus, or the ovary and the pelvic sidewall. So I would probably start there. Pelvic MRI is a very expensive test, and I'm not so sure, in the absence of severe symptoms of endometriosis, is warranted. But I have recently been doing, a more extensive ultrasound, at least to get an indication as to whether there's any severe pathology. Mild and minimal endometriosis probably are not negatively impacting your fertility as much as moderate or severe endometriosis. And so I think you have to differentiate those two. And then if you really wanted a diagnosis, you may want to consider, a definitive study with laparoscopy, because otherwise you're going to go down the path of having this presumptive diagnosis of endometriosis, being treated with Lupron, for instance, for 2 to 3 months before any embryo transfer. And even after that embryo transfer, if you're not pregnant, then you feel like you've wasted 3 months. So I would just, be cautious, unless a test is very, very specific. I'm not so sure it's the answer that you're looking for. The question, have you found that the test for FET timing changes things for those with recurrent implantation failure? I am assuming that you're referring to the endometrial receptivity assay, which looks for molecular markers that identify the window of implantation. And, I think that initial studies seem to suggest that this test was very effective. More recent meta-analysis have questioned whether or not the ERA really makes a difference. But I think it's certainly, if you have nothing else to fall back on, it's certainly a reasonable test to perform and see if making the alteration in terms of the time of the embryo transfer improves your implantation rate. I mean, sometimes we end up trying things just because nothing else has worked. And while that's not completely evidence-based, I think in some instances there are no other alternatives available. How important is semen morphology in fertility if all other parameters are normal and that's the only parameter that's low? And does that automatically mean that you need to do IUI or IVF? What I typically do in patients who have low morphology, well, first of all, let me just tell you, in terms of a semen analysis, when we do the semen analysis, the andrologist stain a slide with 100 and count 100 sperm and look at the sperm head, sperm tail, sperm neck to identify which percentage of the sperm look completely normal, which look abnormal. And all studies years ago demonstrated that fertilization rates were normal if the sperm morphology were, depending on the study, above 14%, and then 4 to 14% it seemed to be normal as well, or just slightly below. And then fertilization rates started to fall off as the morphology was less than 4%. So typically, what we're doing in our practice is if the semen morphology is low, we repeat the semen analysis. For those patients where the morphology is 3 or 4%, sometimes 2%, I feel comfortable offering IUI. And the reason being is there are some men that there's some variability in their semen parameters, and their wives will get pregnant. And it's a low-tech, low invasive type of a procedure. And if it's successful, that's great. That being said, I would only recommend probably 2 cycles. And if that doesn't work, would make the plan to move on to IVF. If the morphology is 0 or 1%, I typically will recommend moving on to IVF directly rather than starting with IUI. Although if a couple really wants to try, you kind of look at the general timeline of what they're trying to do, and 2 to 3 months is not going to change their outcome dramatically. So if a couple wants to try, I will give them that opportunity. But I'm more likely to recommend IVF directly if the morphology is 0 or 1%. Next question, how long after stopping birth control would you worry about not ovulating, tracking hormones after Nexplanon with the home test and the levels are low? Part of this, I think this is a little bit of a difficult question to answer in the sense that most women who were ovulatory before going on any form of hormonal contraception, when you stop that hormonal contraception, either the birth control pill or pull the Nexplanon, the hormonal levels go back to normal, your pituitary resets, and you start ovulating relatively quickly. So I guess the first question I would ask is, were you ovulatory before going on that hormone therapy? Either way, if the hormonal contraception has been stopped now for a few months, I would suggest that you get testing just to look at your FSH, your estradiol, your AMH to make sure that your ovarian function seems to be at least in the normal range or not. You may, just need a jump start with ovulation induction medications such as letrozole, for instance, to start. But I would do the testing. The one thing not to make you more anxious is, patients who have been on hormonal contraception, their ovarian function continues to decline through that period. So I just want to make sure that you haven't developed ovarian insufficiency or something like that, which would have happened anyway, by the way, and didn't recognize it. So how much does weight have an impact on the IVF process? Does it hurt my chances to be overweight? So this is a loaded question. I think that for women who are severely overweight, if you will, BMI over 35, 40, 45 and above, many of those women are anovulatory rather, or have some form of ovulatory dysfunction. So that may be a problem. And then the hormonal milieu, so that the estrogen levels, circulating estrogen levels are oftentimes higher, circulating androgen levels may be higher. And all of those factors may be detrimental to a pregnancy. I say that there are certainly women who are overweight who conceive and have pregnancies without any difficulty. So to the extent that you have the opportunity to try to reduce your weight to and I would say a healthier weight, because not everybody's going to have a BMI of 25 to 27. That's just not realistic, and I don't think it's even reasonable. But you have to think about, not only do you want to conceive, but you want to have a healthy pregnancy outcome. You want to reduce your risk for hypertension during pregnancy, diabetes during pregnancy, difficulty with monitoring the growth of the baby during pregnancy, all of the potential comorbidities that obesity can cause. In terms of doing IVF, the challenges with IVF are a little bit different. So for those patients who are going through IVF at our center, and need either a retrieval or even need surgery, we have an requirement that your body mass index be less than 45. And the reason for that is related to the anesthetic risk. If you're undergoing anesthesia in an outpatient surgery center. So that if you're completely challenged with weight loss, we can refer you to another center that is in a hospital. But in general, I think we would encourage you to lose weight so that you can do IVF at our center. In terms of success rates, years ago, one of my colleagues did a study on the impact of BMI on overall success. I think the study was with IVF patients, and there was no question that with each incremental kind of 5 points of BMI, the success rates in terms of live birth rate, in terms of conception rate and then live birth rate were lower. So I think that, for those women who are very, very overweight, it certainly could have a negative impact on your IVF success rates as well. Certainly when we're doing retrievals, they're more difficult retrievals. It's harder to access the ovaries. Sometimes the ovaries move a little bit more. Sometimes we can't reach the ovaries at all. So, it's not as simple of a procedure, if you will. The other thing that I would say is for those women who are on many of the current weight loss medications, the Mounjaro or Wegovy or Zepbound or can't remember, Ozempic, because of the risk of, or because of the delayed gastric emptying, if you're going to have surgery, the recommendation is that you stop these medications 1 or 2 weeks before your surgical procedure is scheduled. Likewise, for women who are trying to conceive, there's not a lot of data with regards to the impact of these medications on a pregnancy. So the current recommendations are that if you're on these medications, that you stop them before you try to conceive. I have some patients who are really challenged with doing that, so we stop them at least once we know they're pregnant. But again, the recommendations are to stop before you try actively to conceive. Does Boston IVF transfer aneuploid embryos and or multiple embryos? So quick answer, aneuploid embryos we do not transfer. We might transfer a segmental aneuploid embryo, as I mentioned early, with the appropriate genetic counseling. And then multiple embryos, we follow the guidelines by the ASRM. So those guidelines really encourage single embryo transfer for most women. And then over the age of 38, there are, depending on whether the embryo is genetically tested or not, we would then consider transferring 2 embryos. Over the age of 40, we might be a little bit more liberal with untested embryos, transferring 3. But typically, the recommendation is single embryo transfer as outlined by the ASRM guidelines. The insurance companies have adopted these guidelines as well, so they will not author, if you don't meet, the criteria, they won't authorize treatment. Question, do you prefer Menopur over Gonal-f during an egg retrieval cycle? So they're different. Gonal-f is a recombinant FSH. Menopur is highly purified urinary FSH. In many instances, I use a mixed protocol with more Gonal-f than Menopur, but still a mixed protocol. And then there are some cycles, in particular the microdose Lupron cycles, where I use either Gonal-f or Follistim, the pure recombinant FSH, alone. Some of my colleagues use Menopur as the second agent. Others use a dilute HCG as the LH component. And then what about Clomid over letrozole? In anovulatory patients, my preference is letrozole over Clomid. Side effect profile is better. Efficacy is equivalent. In ovulatory patients, I don't know if it really matters, but I tend to use letrozole in most patients because it has fewer side effects. Does acupuncture work for infertility? So the thing that I will say is, years ago, there was a study, I believe it was out of Germany, looking at acupuncture pre and post embryo transfer, suggesting that acupuncture improved outcome. We then conducted that same study here at our Mind Body Center, and were not able to demonstrate an improved likelihood of pregnancy. It wasn't better, it wasn't any worse, it was the same. That being said, I think that acupuncture provides you with an opportunity to relax, kind of decompress both pre and post embryo transfer, but I can't say that it's going to improve your overall outcome. Same person asked about the low motility count. Do I recommend seeing a urologist before a fertility specialist for myself and him? I would do them concurrently. I think the key is there are only a few urologists in the greater Boston area that have a particular interest in infertility, so you'd want to make sure that you identify who those urologists are. What are the statistics of conceiving with letrozole alone in patients with PCOS and the male with low morphology, but all other parameters normal? I think that the success rates with ovulation induction with letrozole in women with PCOS suggest that their pregnancy rates per cycle are probably in the 10 to 12% per cycle. The low morphology, if that's the only finding, it may not make a difference if it's 3 or 4%. The success rates may be lower if it's 0 or 1%. So what's the percentage of implantation for a 43-year-old with no fertility issues and a normal uterus? When we looked at our implantation rates for our embryos, the implantation rate, and this is not specifically for a 43-year-old, but you can somewhat impute this data, is that the implantation rate for women over the age of 40 is probably 7%, 5 to 7%. So a 43-year-old, most practices aren't even offering IVF or offer it in very rare instances for women over the age of 43. But I would say an untested embryo, probably 5 to 7%. AMH level is above 4. I'm 36. Does that mean the quality of eggs are good as well? I think that an AMH of over 4 in a 36-year-old, I would anticipate that you would have good quality eggs and that you would have a good yield with IVF if we were to stimulate you. That being said, again, I would recommend, if all other things are equal and normal, try IUI a few cycles first, and if you're not successful, then move on to IVF. What's the success rate with letrozole for a woman with a low AMH? So an AMH, a normal AMH in our lab is 1, but the reality is a woman with an AMH of 1 probably still has diminished ovarian function, and you'd like most women who respond really well have AMH levels that are probably 1.5 to 2. So if you have an AMH of 0.3, that's really, really low. And the likelihood is that you might only respond and get 2 to 6 embryo or 2 to 6 eggs, and therefore may only have 1 to 2 eggs. And that may result in very few embryos. So I would say your likelihood of success is probably 5% per cycle if you ovulate. And with IVF, because you're not going to get lots of embryos, it might not be more than 10 to 15%. Are there differences in implantation rate between an embryo that's a 5AB, 4AB, and 4BB? When we categorize embryos and look at implantation rates, we lump all of those embryos together. So I would have to say no. That being said, our algorithm for transferring embryos is first we start with the AA. Well, first we start with embryos on day 5 and 6 before embryos on day 7. We start with grade AAs before BB. I'm sorry, AAs before BAs before ABs before BBs. But again, when we do our statistics, we lump them all together. And then we start with, say, stage 6 before 5, before 4, before 3. And then so an embryo that was a 3ABB is an embryo that we would freeze. And I would say it's a good embryo. So that answers the next question. Somebody was asking about lots of supplements. So I will comment on a few of them because there's some of them that I don't know. But inositol is usually, if we're going to recommend that, we recommend that for women who are anovulatory and hyperinsulinemic, because inositol, both myo and D-chiro, integrate into the insulin pathway and it may decrease insulin resistance. I think omega-3s are fine. I can't comment about NAD, NAC, or glutathione, or colostrum. I really haven't followed that literature. Probiotics, there's some data to suggest that probiotics and making sure that you're taking probiotics so you have the appropriate amount of some lactobacillus, which is the normal lactobacillus that's within the female reproductive tract, is a good thing to do. So I think that that's fine. And then Claritin and loratadine, there is a protocol that's been circulating about an antihistamine protocol improving implantation rates. I will be honest, I've used it. I'm not so sure it works, but it includes Claritin, Benadryl, Pepsid, and something else that I'm forgetting at the moment, none of which are harmful to the cycle or harmful to the patient or harmful to the embryo, and prednisone. So I think that's certainly something you can discuss with your physician. I'm not so sure if it works. So chances of a natural birth post hysteroscopy removal prior to children at age 40. It all depends on what the hysteroscopy was done for. Some hysteroscopies are very extensive, removing fibroids, etc. And there's a higher risk of adhesion, scar tissue, potentially a lower risk of implantation. If it's a hysteroscopy for polyps, that shouldn't have any impact on implantation rates. If it's lysis of adhesions and they're filmy adhesions, then that's probably okay. For women who have very, very extensive intrauterine adhesions, lysis of adhesions requiring multiple procedures, the implantation rate in that instance is really, really poor. So it kind of just depends on what you had done. And again, if the embryo comes back, this is in response to the conversation that I had about miscarriage and genetic testing. If it's euploid male or euploid female of fetal origin, then those indicate products of conception that were tested. The question of a high BMI, how much folic acid should you be taking? Generally, the recommendation for all women, almost I think irrespective of BMI, is at least 1,000 milligrams of folic acid, and the dose of the equivalent dose of methylfolate. The only people that really need to be on much higher levels of folic acid are those women who have a family history of neural tube defects, are on medications some of the antipsychotic medications, for instance, or and anti-seizure medications, which might require a higher dose of folic acid. But again, I would discuss that specifically with your physician. Hysteroscopies with small polyp removals will not have any adverse effect on pregnancy outcome. If a patient is freezing eggs for fertility preservations, once the eggs are retrieved, can we better tell them about their egg quality? The answer is really no. I mean, we can tell that the eggs are mature or immature. So those eggs that are mature are the only ones that are likely to fertilize. We will sometimes fertilize those that are kind of in between. They're called metaphase 1. They're in between the very, very immature and the mature, and sometimes those will mature in the lab. So we'll freeze those. But we can't speak necessarily about egg quality. You can't look at the eggs and know whether they're going to be healthy or not. This is a question about Pregmune testing, and I'll be honest, I don't typically order Pregmune testing, but I've seen patients who've had Pregmune testing, either in instances with recurrent pregnancy loss or recurrent implantation failure. And that testing includes a lot of the testing that we would do, and then other things such as HLA testing, natural killer cells, and certain other tests that are indicative of inflammation. And oftentimes the recommendations are, pretty benign. And then some of the recommendations are for infusions of intravenous immunoglobulin, for instance. And so I think if we were going to go down that road of Pregmune testing, I would want you to go to the providers, and there's a center in New York that can provide you with counseling about the efficacy of their recommendations. It's not something that we routinely do, so I don't want to comment too much about it. Can adenomyosis, and we're almost winding down to the end, can adenomyosis affect my fertility? So adenomyosis is where there are glandular endometriosis glandular tissue that invades the myometrium, which is the muscle of the uterus. And it can either invade the muscle of the uterus somewhat diffusely, it can form into nodules or what we call adenomyomas. And so there's some people with adenomyosis that if the uterus is severely impacted with adenomyosis, may have difficulty with implantation. Mild adenomyosis probably doesn't have an adverse effect. So it really depends on the severity of the adenomyosis. You can have it further evaluated by ultrasound as well as MRI to determine, again, how much adeno there is. What are vaginal suppositories like? Are the PIO injections more effective? So we use vaginal suppositories exclusively in either in an occasional IUI cycle, not typically with IUI at all, because we're not manipulating the ovary, in our modified natural and natural frozen embryo transfer cycles. With our synthetic estrogen transfer cycles, where we're giving you estrogen and waiting until the lining gets thick enough before we start progesterone, we use a combination of progesterone and oil and vaginal, or progesterone and oil exclusively. And that's because with the modified natural cycles, there is a corpus luteum that is produced that is supported by the HCG injection. So your body is producing progesterone. We're just giving additional progesterone, and it's probably more than you need, but it makes everybody feel better. With the synthetic cycles, you need to replace progesterone. So thus the intramuscular alone or intramuscular every 3 days with vaginal. The suppositories are just that. They're suppositories. You place them in the vagina, they dissolve. The progesterone is absorbed locally. Serum levels will not detect whether or not they're adequate progesterone levels, because you can't measure that in the serum effectively and reliably, but it's effective locally. On the progesterone injection oils, in PIO injections, you can monitor serum progesterone levels. The average range cost of IVF versus IUI, it varies from center to center. So I would prefer to defer that question to one of our financial coordinators. And if you are a patient at Boston IVF, you have a financial coordinator who will be able to go through the cost structure for IVF with and without ICSI if you need that, for just, pre-implantation genetic testing, embryo freezing, embryo storage, etc. What's the timeline for getting pregnant after scheduling a consult with a fertility doctor? I think most patients, once they've finished their testing and go through treatment, most patients probably are pregnant within 6 to 9 months. That being said, there are those patients, that requires you got to keep things moving. If not, there's some patients, it takes longer than that if they need surgery or what have you. So it just varies. Can I do IVF if you're pre-diabetic? The answer is yes. Depending on what the level of your hemoglobin A1C is, we may recommend you have a consultation with a maternal fetal medicine specialist first, because in all likelihood, you'll develop gestational diabetes during pregnancy. Let's see. Any reason why my anti-Müllerian hormone would fluctuate from 2.6 to 1.4 in a period of 2 months? And this is a laboratory test, so there are fluctuations between, in the levels. I would not worry too much. I think either of those levels are pretty normal. So, the question is whether the assay changed, but in most instances, one cycle you probably had more small antral follicles than you did in the other, and it's the antral follicles in the cycle in which you're having the testing that determine the AMH levels. So AMH is 2, AFC is 12, diagnosed with bilateral endometriosis on ultrasound. Sperm morphology is 1%. Would you suggest ICSI or IUI? I would probably, well, it depends on the size of the endometriomas in the ovaries, because you may want to do IVF, freeze embryos, if you're considering surgery. So I would probably do IVF with ICSI because the morphology is 1%. My thoughts on the Mucinex method, I can't comment. I don't know what the Mucinex method is. The only thing I would guess is maybe it's to improve cervical mucus, the viscosity of the cervical mucus, but I don't know if it works or not. Is there data on whether it's better to freeze eggs fertilized versus unfertilized in order to increase the chances of live birth? That's kind of a loaded question. I usually would freeze, well, it depends on whether you're partnered or not. If you have no partner, then you need to freeze eggs unfertilized. If you have a partner, then freezing embryos is going to result in better success rates, because you know what you have, and you can freeze embryos. You could have them genetically tested, so you know that you have a better shot of pregnancy based on our data. The only challenges to freezing embryos that I say to couples who are doing elective fertility preservation is, just be mindful of the fact that if there is, a split in the relationship, then those embryos can't be used. So many times I will tell women in particular, because it's much harder to get eggs than sperm, to freeze eggs. And then that way they will at least always have those eggs available. It's really hard when you have to discard embryos in the event of a separation or divorce. So with that, it's 8:04. Lots of questions, all very good questions. And I think I got through most of them. So I volunteered to do this because I always find this a little fun. And so I hope I was able to answer your questions. If not, direct questions to your physician. Our financial coordinators are available to chat with you. And hope this was helpful.